coming back to that, I think the first question probably when we see a patient with a diagnosis of DLBCL that has been recently made is how do we segregate eventually patients into different categories, and what are we using for that? I think that's probably the first question that I would like to ask. And maybe I come with this question to you, Greg, and asking, when you have a patient coming into your clinic, what are the key factors that you will like to take into consideration, during the first half hour before requiring additional tests?
Thanks, Gilles. So one of the probably primary questions is the patient overall performance status or comorbidities, because this can affect the future choices of therapy. And that's one of the first things which really comes up with management of those patients. The median age for diffuse large B-cell lymphoma is 67. A lot of those patients will be elderly and have multiple comorbidities, and that's definitely the area of unmet need. Then it follows typically by staging and traditional clinical risk factors like IPI in assessing the risk for the patient of progression or death from lymphoma, and that's typically done on a clinical basis before further molecular testing on pathology slides, which we typically get at the time of diagnosis.
Thank you. Catherine, any insight from the other side of the Atlantic?
I totally agree here with Greg. So first is the patient characteristics, and then the disease characteristics. So patients, as Greg said, have the same feelings, so age, comorbidities, and then regarding the disease characteristics, maybe I could add also the CD20 expression and CD19 expression now that we could add as criteria that are maybe important to choose for the treatment. But IPI, state of course, external sites, and TMTV. I know that in this side of the Atlantic, we may use this parameter just to understand better the bulk of the disease, the aggressivity of the disease, and we have implemented in many centers to analyze the TMTV and to calculate the TMTV at baseline.
Thank you, Catherine. So maybe let's move forward and ask Andy what he thinks regarding the characterization of the disease and getting a little bit more insight of what is the pathology, what are the insight. We are focusing on first-line therapy here, right?
Sure. I mean, so of course, we've been very interested in the molecular phenotype of diffuse large B-cell lymphoma, and we've been in a position to present some data with a long-term follow-up of our study demonstrating that maybe the ABC subtype may have a differential benefit from the addition of bortezomib. That's, I think, is still something that is investigational, and it relies on the fact that we determined cell of origin using a transcriptional profile rather than using immunohistochemical surrogates, which just simply give us a binary, is this a GC or is this a non-GC? So I think in clinical practice, we're a little bit away from that. What I do want to know in clinical practice, however, is I want to know whether there is a double hit, whether there's a MYC or BCL, and or BCL2 translocation, because I think clearly that puts your DLBCL in a different diagnostic box, and I think for some people at least there's a different approach to therapy. You can believe or not whether you think these patients particularly benefit from intensification of therapy. But I think from my perspective, some of these disease-related features are important, but actually I really want to know a lot about the characteristics of the patient, and I really want to understand the IPI for that individual patient to help me think about what type of treatment I'm going to give and how much type of treatment I'm going to give. And that, I think that's really key for me, is knowing where they are in the IPI scores. Maybe
I will ask Astrid to give us her feelings and how South America these things are being handled?
Well, I agree with everyone's opinion on what matters at first line. I would maybe add that also regarding the urgency of starting treatment, both what we see on the PET-CT and the laboratory abnormalities. So that's something to take into account in our first approach to the patient. And obviously age, comorbidities, and the patient's desire, of course. And regarding the pathology, we don't take decisions on the cell of origin at first-line treatment, and we always try to have the molecular analysis to see if patients are double hit. In many cases, we start asking only for the MYC fish, and then if that is positive, we go on to asking for BCL2 now. And I think regarding this question and also what we mentioned before, I also think we have this new struggle to see how we incorporate the two new lymphoma classifications, right? And how are we going to mention diffuse large B-cell lymphomas or all the other subtypes regarding these two new classifications.
I think regarding the double hit and the management, we learned over the few years that this is even an heterogeneous group of disease, and the question of, first of all, some patient carrying a signature that is kind of double hit, but also the fact that depending on the IG partner, there are differences in outcome of this patient carrying MYC and BCL2, and the question of the signification of MYC and BCL6 has been already challenged. Kieron, you have been having a lot of interest on this question, and I heard you on a presentation recently on this topic. Can you give us a little bit more insight regarding what is new in this field? Is it a whole bucket? How to identify patients? Are there different patients with different features that you may consider?
Yeah, so I think it's a complicated spectrum of diseases. I mean, I think that those cases that have a MYC and a BCL2 translocation, we have some, good understanding, I guess, of the bad prognosis of those cases, and that they should be treated differently. But there are other aggressive B-cell lymphoma cases that don't have a MYC and a BCL2. Some have a MYC, some don't have a MYC or a BCL2 translocation. But as you said, there are some studies that have looked at a double hit signature, and a high proportion of those cases have not got the hits. So in the clinic, I think we often see cases that especially have a high proliferation rate, but oftentimes haven't got the hits, and should they be treated, treated differently? These are sometimes called high-grade B-cell lymphoma NOS, but in the clinic, it's a challenge, I think, to identify those cases, and there's a lot of different opinions about which cases should be put into that category. So I think we need to do more work in better elucidating these diseases, especially on the interface of high-grade B-cell lymphoma and diffuse large B-cell lymphoma, outside of the ones that have a MYC and a BCL2 translocation.
So maybe we can move on to the treatment choices, and maybe Marek, I can ask you to summarize a little bit what are the. We talk about the elderly, maybe the older patients, maybe we can put them aside for 1 minute and come back later to that. But in patient without significant comorbidities, how do you put your treatment choice in the first line setting nowadays?
Yeah, thank you. So this is very easy for us because the R-CHOP is the only real world option we can use. So it means that outside of the clinical studies and until the POLA hopefully will be reimbursed, we do not know which subtypes or which narrowing the regulatory agency pick up at the end. So this is the R-CHOP. So sometimes I think that what is very important, it's we have discussed the prognostic features, I think that the early response to the or the midterm response to the treatment is very, very important. We are still missing solid, robust data to change the treatment, but there is the accumulating evidence that we can do more for those patients, and definitely for the let's say elderly population. So I think that the new chemo-free regimens maybe could be available in the future. But to be completely honest, I do not think that we are very close to the accepting or using this information in the real world practice within the years from now. So although there is a huge amount of accumulating data, new possibilities in the real world, we really still are based, and we still use the R-CHOP.
Miles, what's the situation down under in Australia?
Well, it's very similar. I think people have somewhat religious beliefs in treating certain things in certain ways. So if we touched on double-hit lymphoma, there's centres that will use dose-adjusted EPOC. Patients who have primary mediastinal B-cell lymphoma, there are some centres that will really try and push radiotherapy. Others will try and avoid radiotherapy. So I still think there's controversy in some of the subtypes. I think Marek's clearly said, for the bulk of patients. I'm particularly interested in some of the unusual, we know the ones that are addicted to the B-cell receptor, so breast lymphoma, testicular, brain, and primary cutaneous B-cell lymphoma of the skin, leg type. Those have particular patterns and often molecular patterns that fit with the B-cell receptor pathway, so use of BTK inhibitors. So I think we are getting a bit more fine-tuned. I think one of the big areas that we often discuss at our MDTs is the use of radiotherapy in early stage disease. And how much do we cut back chemo and add in radiotherapy? And I'd say that's probably on a day-to-day basis, that's one of the more controversial aspects that we have. Some believe push the chemo, others say reduce the chemo and give radiotherapy. Others say, if it was me, if it's bulky, give me as much chemo and radiotherapy. So I think that's, there is still, a good old CHOP, but around the special circumstances, there's still some challenges and clarity.
Maybe before going back to Germany, which I've picked up quite rapidly with the use of POLA, from my understanding, and because you touch upon the role of radiation therapy, I may ask Alison, who may have a view based on her expertise and management of Hodgkin, but also primary mediastinal, about what she feels about that.
Well, with primary mediastinal, I feel like for the most part in the frontline setting, I'm able to avoid radiation therapy, or I aim to avoid radiation therapy. And I think, if we're using more intensive chemotherapy, such as dose-adjusted our EPOC or our Sloan Kettering regimen with the sequential R-CHOP rice, both of those regimens seem to have very good outcomes, and with very few patients ending up needing radiation therapy. And for the patients who do end up having either primary refractory disease or relapse disease, I often am using radiation therapy in the second line setting as part of their consolidation strategy. But for the most part, I'm able to avoid radiation therapy in the frontline setting for those patients.
So Martin, I heard from my colleagues from Germany in a meeting recently that the availability of polatuzumab has really been kind of taken as part of the current practice in Germany. It has also been now in the US designated as an option of high impact in the NCCN guidelines. So what's your experience? What's your impression about that?
Well, let's first of all pick up what Miles said. I think that's interesting. We all know the randomized trials, but at the end of the day, what we're doing in clinical routine is partly belief, let's say it that way. And for myself, I'm a strong believer in simple rules. And when it comes, for example, to prognosis, this is really for me driven by patient performance status, which is related to age. That is what the patient can tolerate. And secondly, simple thing, LDH, quantitatively, which is really from my experience, my clinical experience, overcoming at least some of the molecular makeup. Having said that, so what are our rules how to treat first line? Well, you're right. Polar-CHOP is first of all reimbursed, and it's already included in our guidelines according to the large randomized trial. So how are we applying this? Well, this is the results are somewhat mixed because we do have a significant improvement of PFS, but not overall survival. And therefore, you try to pick the subset of patients who benefit most. And therefore, everyone looks into the forest plot of PFS, and there are a couple of risk factors, namely age, ABC versus GCP, and IPI 3 to 5. And how do we implement that in clinical routine? I said I love simple rules. So for patients, IPI 3 to 5, this is where we see Polar-CHOP in our CHIP in our institution. Now, you might say, well, there is this German tradition of R-CHOP, and you might requote that as the German version of EPOCH-R, light if you want so, because we don't increase the dose, which is exactly positioned in the same kind of patient subset, right? And there is a case control study going on comparing these individual patient outcomes. My best guess is that it will be similar, but Polar-CHIP will be better tolerated.
Thank you. I think we will probably like to wrap up unless there is a 30 seconds opinion, and I will try to wrap up. But I think, as we said, again, while this is a very common disease, there are different categories of patients. And while we didn't have the time to go in detail regarding the management of patients with impairment of the status for older age or comorbidities, it's important to address those. I will also take the sentence of the colleague of Greg Tom Witzing saying DLBCL is a medical oncology emergency. These patients need to be handled rapidly, and I think in different places this may or may not be always a fact. The second thing is taking a part of that, we have obviously patient with localized disease, and results of the trials such as FLIER and others indicate that the management of this patient with 4 cycles of R-CHOP allows to cure the vast majority of patients. And then we have the patient with more advanced stages where the question of the biological definitions, how to implement those, how to bring them into clinical practice, and how to handle the different regimens that have been used, either dose-adjusted IPOC for patients with double hit, the introduction of polatuzumab in the Polar-CHIP regimen in the randomized trial of POLARIX, I think are raising new questions. Obviously, we will probably learn in the near future. What I should add also, and because this was touched upon, I think, by Marek regarding the interim PET and the way we have been used to adapt treatment, is that we probably have to integrate the availability of CAR T-cell as a second-line options for patients who are refractory or failing therapy. And that compared to our old study and old concept about that, finally, you know, we don't need to change early on, but we can identify, because the data are pretty strong, that some patients with interim PET result positive, depending how you define them, are those that are high risk of failure, and that you can, in your mind and maybe for the patient plan, to eventually indicate that this will be an option if treatment fails. So an exciting field, an exciting way to go, many questions from also bortezomib, etoposide, also I mentioned, and how to bring into clinical practice this molecular testing is a double hit signature, the MIC partner and others. And I think there is a lot of work still to be done. And it's a field that is well established with R-CHOP as a backbone, but with some subtle variation and possible improvement that hopefully will improve the outcome of this patient in the near future.